Right. So it's titled as Arteries, Muscles, Valves, Electrics, the Way Forward. And generally covers a range of things. And the first one I would like to highlight perhaps is what we know and what we've learned from something called ischemia trial. So these slides will be available to you to view later, but just every slide may have an important take-home message. The ischemia trial was a big study performed a couple of years ago, which changed the practice around the world of how we used to deal with ischemic heart disease patients coming to clinics with angina, not acute coronary syndrome, but angina. And it was a randomized, or the largest of its kind, randomized with people with ischemia, moderate to severe, randomized to have either medical treatment or medical treatment along with invasive or surgical treatment. And at the end of the trial period, primary outcomes, there was no difference whatsoever in terms of cardiovascular deaths, myocardial infarctions, hospitalizations, or resuscitated cardiac arrest. So this was really path-breaking, and it meant that we needed to learn from what we had learned already from before, that continue with good medications and good medications, and optimize them as much as possible, and only subject people to PCI, stenting, surgery, etc., if they have symptoms and despite the trial of medical management. So this was a very, very path-breaking trial. There was questions raised as to, okay, well, this is at 3.5 years or so. What about longer term? So this ischemia extend, which was published early this year, presented 2 months ago. Again, similar results at about, you can see that this another follow-up 5.7 years approximately. And there's a separate trial going on with CKD. And the learning point, and we will know more about in about 2026 or so, but the learning so far is that that there's little benefit, if at all, with revasc unless patient is having uncontrolled symptoms or poor quality of life. There's a raised hand. Speak out, please. Thank you.
Yeah, I just want to ask, what was the criteria for stenting people in the trial?
Just symptoms despite good medical management.
Did they do it based on like physiology, like FFR, or was it purely sort of
No,
guides?
it was all evidence-based with moderate to severe ischemia. Everybody had to have moderate to severe ischemia before entering the study. Does that answer your question?
Yeah, I was just interested to know how they decided which lesions to stent when they went into the trial.
I think they stented whichever was the culprit lesion, which was dealt with in terms of if you're talking about the hemodynamic significance, then all the lesions which are hemodynamically significant, which we call as near complete revascularization, anatomical or functional. There can be two ways. Either you look at it and you think it's tight and you deal with it, or you do a proper study to check whether it's significant or not. And there was evidence that anatomical or functional complete revasc as much as possible, as happens in STEMI scenarios, was perhaps better. But again, we will learn a bit more later on. That so far, the ischemia study did not show any difference, as you can see here. I think that is a separate topic for discussion. I'm more than happy to engage with you to discuss some of the vagaries and some of the details of ischemia trial and unanswered questions, in a separate session or through an email trail if you wish to. You're more welcome.
Yeah.
Okay. In fact, we did a teaching session for cardiology registrars just very recently on this particular topic, including the completeness of revasc. Thank you. So moving on. So this is the ischemia extend, and you can see that there is a little bit of divergence of curves, that this more severe disease you have, there may be a reason to worry long term, but still, I think you can have decent outcomes at about 7 years, but maybe 2026 might tell us a little bit more that we should perhaps revascularize people with more severe disease and evidence of definite ischemia compared with just giving them medical management. So that is one take-home message in terms of what's new and what's recent. In terms of stent work, I think you guys are well aware of what's going on, having worked in cardiology at some point or having exposed yourselves to cardiovascular medicine in different ways. Majority of the work done to the coronary arteries these days is through radial approach. As you can see, more than 90%. The bare metal stents without any coating of medications on them or without them having a non-metallic structure in terms of bioabsorbable scaffold are hardly used unless there are definite reasons that you don't want to really give long-term DAPT and all that stuff. And then the rationale for bioabsorbable scaffold traditionally was that, okay, well, in time to come, they could be perhaps absorbed as part of the vessel wall, and there wouldn't be a need for long-term DAPT. They should not interfere with imaging studies like MRI and CT, and potentially there would be no late thrombosis of stent, etc. But some of those things were proven wrong, and they have a very niche role where we would use bioabsorbable stents, not in every case or default as a default strategy. So just to keep in mind that we've come around full circle in terms of biological structures, thinking as part of the nature, they would be the best option, which I don't think at this point in time we can say that they are. So that was something which I wanted to just cover in one slide. And that was the whole rationale that perhaps, the biocompatible, the right mix, using all the right ingredients, you produce a meshwork which goes in, gets absorbed, and becomes part of the vessel wall, and then you don't need anything else there. But perhaps that's for a limited number of people, patients, and where you could have concerns regarding, I'd say, DAPT and other things where you would use those sort of scaffolding. Advantages of neostent generally is mainly around dual antiplatelet therapy, that you can reduce them to as low as 1 month now, to be honest, with the current generation of stents, even drug-coated stents, with much less restenosis, which is like going forwards, they wouldn't narrow from inside, much less stent thrombosis, primary PCI default is drug-eluting stents. And where not specified, I think you would still say that you want to give them 12 months of DAPT because of the ACS evidence so far. But you can adjust them, as Joseph showed you a slide. If somebody needs an anticoagulation strategy along with antiplatelet strategy, then you would bespoke, tailor-made a plan for them in terms of 1 month, 3 months, 6 months of DAPT, along with anticoagulation or triple therapy, followed by single anticoagulant plus single antiplatelet rather than dual antiplatelet. So that varies from case to case, and there are established guidance, but guidance is guidance. You would make a decision based on patient parameters and what exactly has been done, so on and so forth. But the shortest period is now, as short as 1 month or so. And for the highest risk patients, where you worry about them, that they might have problems, multiple stents, multiple vessels, very high cardiovascular risk, you have the option of giving them long-term DAPT, which is like more than 2 or 3 years after conventional 12 months, where you would extend the ticagrelor. It comes in a 60 milligram tablet option, then 90. So after 12 months, you change the 90 to 60 twice a day and give them for 2 or 3 years, and hope for the best. So that is an extended DAPT regime, just to add on to that. The other thing which perhaps your colleague was just referring to was ischemia-driven treatment, which is like, that's the true revascularization. You don't really want to just see the angiogram or or the picture and see that, okay, well, and decide it's tight, let me put a stent in. No, that's not the right strategy unless it's really tight, unless it's occluded. But here it's something about, putting something in, an equipment, a sophisticated technique, and assessing whether the pressure difference across the two sites before and after the stenosis is significant enough, which is about 0.8. If it's 1, then 0.75 to 8 is what percentage-wise, and that comes to a ratio called fractional flow reserve, or FFR, and that perhaps gives you a very high degree of sensitivity and specificity and confidence to proceed with what you want to do at the time. And that's called ischemia-driven treatment, which is the default strategy currently around the world, or around UK cath labs, UK practice in general. We don't necessarily proceed just based on angiographic appearances unless it is really tight, more than 90% or so, or occlusion. So that's something which should be kept in mind. And that's how it looks, that you can see that the moment, so if that's the aortic pressure, that's the coronary artery pressure, they're both in line with each other. And the moment you have a drop distal to the stenosis, you can see that here the value coming after you've dilated the vessel maximum possible with a medication like adenosine, it is showing you a value of 0.74, which means there is significant stenosis. That stenosis is hemodynamically significant, and you may decide to treat it depending on the location, depending on whether it's doable by the using the technology you have to hand. Imaging of the coronary artery from inside is quite prevalent now, and without imaging, I don't think majority of operators are performing procedures currently, especially you have more complex disease with calcium around it. So you can see here how beautifully this intravascular ultrasound reveals a vessel which is absolutely normal, that the black spots, this is blood, and that's the catheter itself, whereas this is a disease vessel with a rim of calcium from about 11 to 2 or 3 o'clock, followed by another layer of fibrocalcific disease. And the lumen itself is restricted, as you can see, with the catheter in the center. So that's a good example of intravascular ultrasound, or IVUS as we say, which is pretty much used around the country and the world as the default. It's available at hand, very quick to use, and you can assess the whole vessel as much as you want to with a careful approach, not to cause a complication. Another generation after IVUS is called optical coherence tomography, or OCT. You might have heard this in ophthalmology and a few other specialties, which is a very quick procedure where you just pass a wire and gradually withdraw it, and you get fantastic images of the vessel from inside, which here, which has multifaceted function to give you information about whether there's a thrombus or dissection or a plaque. And if you put a stent, then whether that stent is hanging in the lumen or whether it's opposed to the walls of the artery. These are the struts of the stent, can you see here? Whether it's expanded or under expanded, and also the area of the vessel. So, and anything else which is protruding into the lumen. So I think there's loads of information you can get from OCT. OCT is available in most of the cath labs. Initially it wasn't, but currently we have it. And it just aids to get the best possible outcomes from a procedure, I would say. And that's an OCT in practice. So you just withdraw the OCT wire and catheter, and then you get this sort of a portion picture, and you get this area where you have a stented segment. So this is how it looks on the OCT screen, and then you make your decision as to how you want to proceed further, stop, or carry on. Limitations of luminal angiography, of course, have been realized of late, that it just gives you the lumen and nothing else, whereas few other tests could give you a bit more in terms of plaque burden, morphology, composition, and whether you should assess the function um, um, in terms of a stress test or an invasive test, or whether you should just evaluate anatomy. That debate continues, but right off late, the consensus seems to be that the more you know about the anatomy, the more better you can manage the patient. But the strength of ischemia testing continues to be risk prediction. This was discussed at length in the ESC meeting 2 months ago, that we will never be completely away from this, and we'll have to combine the two technologies together. And the more severe the ischemia, the more risk the person would carry. That's been proved over time and again. And in somebody with angina and or dyspnea, which could be an angina equivalent and suspected CAD, you could see that these are the likelihood of invasive angiography finding a significant CAD. You can see how low probability is just a stress ECG, which is like a treadmill, I'm saying, compared to CT coronary angiography, which has one of the highest probabilities, compared with some of the nuclear scans. Stress echo is here, and SPECT, thallium, and PET scan are here. So basically, all it says that the more you know about the anatomy, perhaps the better you can manage the patient. CT coronary angiography, I think for those of you who have watched any CT image of a cardiac CT angio would perhaps know, or if not, then you can see how beautifully it demonstrates without the need to go invasive, the whole coronary anatomy, apart from, along with some of the best possible images obtained of the anomalies of the coronary circulation, assessment of grafts, and also function of late with the technology. And most recently, we can also assess the functionality across, the function and the hemodynamic significance, or what we call as FFR, from CT, and also the burden of myocardium affected, and actually help our colleagues to plan the whole procedure based on CT itself, compared with invasive, or maybe bypassing the invasive testing altogether. And this has been proven and shown recently. And this is what the CT offers. It doesn't just offer the luminography. It also offers plaque analysis and helps to pick up plaques which are non-significant, and you can then provide statin to those patients and prevent them from progressing further. And we often do it in our clinics where a CT has picked up a 25-30% plaque, and all you want to do is to give statin, so that where we would have never picked it up on invasive angiogram. So that is a major way forward in CAD management. So remember in mind, CT coronary angiogram is now the first line test for coronary artery disease in elective planned settings, unless the patient is quite old, where the burden of calcification is likely to be high. This is just a pictographic representation of a CT coronary angiogram. So if you follow this arrow, you can see that there's a good lumen, which is like, quite well opacified, and then the left main coronary artery coming from the left coronary sinus. This is the left ventricle. And then you've got this artery called the left anterior descending, running on the anterior surface of the heart. And this showing a little break here, and that's the tight stenosis in the LAD itself, profiled in another view, again similar appearances, and reconstructed in 3 dimensions. You can see that this is what it would look like. So that's the power of this test. And for grafts, again, it's equally valuable. I think there can be no better test actually for people with bypass surgery in the past and coming back with symptoms where you want to really, sometimes you have no information as to what grafts they had. So this is aorta, as you can see, big round structure, and a channel is coming out of this, which has a bent and a narrowed appearance, which on the reconstruction looks something like this. So that's a notched stenosis in a venous graft, whereas the other channel here going down seems to be quite well patent. So it just gives you the option to do everything without subjecting the patient to potentially risky invasive procedures. And also, as I said, lesion location and subtended myocardium, which means myocardium at risk. We can now provide this information through CT scan in terms of which vessel and how much myocardium at risk, so that decisions can be made about revascularization and treating the particular segments. And this is always referring to as CT-FFR. That's being routinely done. I think we've tried to have this in our trust, so far unsuccessful, but we might go forward with this in near future. We do a lot of CT angiograms every week, and we do see a lot of pathology. So this is a good way to try and get as much information. As you can see, this slide from a month ago, discussed in the BSCI meeting, could actually look at the whole circulation and calculate the FFR, or the hemodynamic significance, at different levels, and provide a three-dimensional reconstruction of the whole coronary anatomy, and then provide information about this is how we should be planning a procedure, and asking your colleague to choose this sort of a strategy, that sort of a strategy, avoid this, avoid that, and eventually, if you can see this is the same patient actually having a long, this white thing all here is the calcium along this left anterior descending, and a branch coming out, which is diagonal branch, taking the calcium off. You can see there's a tight stenosis here, and beyond this. And if you equate that to the actual coronary angiogram, this correlates pretty well. See similar appearances with a tight stenosis seen at this bifurcation. And this patient actually had a CT-guided PCI without the need to having to undergo initial angiogram. And this is the result after a stent was placed from here to here. And that's the long stent, as you can see. Can you see that? This little faint meshwork seen across this whole vessel. And this is how the procedure was planned. So see how advanced this has become now, that you could actually provide the right view that, okay, well, use this view, and you should use this length of stent. Patient actually had a 48 millimeter stent, which is the longest possible, to be honest, and covered the whole segment, which is here. And that treats this lesion from here to here effectively. So this is just an interesting perspective. And this is the first in-man trial where there's been an embargo put on for publication because there's a fear that some of the cath labs might close down, perhaps. Fast Track CABG, that's the name of the trial, where 114 patients underwent cardiac CT in heavily calcific lesion disease, and surgeons accepted them for cardiac surgery or CABG without the need for invasive angiography. This is a path-breaking study which was presented 2 months ago, and it's going to change the whole landscape of how we're going to assess coronary artery disease in coming future. So that's just something to keep in mind. Cardiac MRI, you would have reported, or maybe you would have mentioned the reports in the notes and read them in different ways. It's one of the best methods to assess structure and function, whether the muscle is viable or not, whether there's any ischemia by inducing stress, whether there's a scar, whether inflammation like myocarditis, infiltration like sarcoid, abnormalities of the aorta and coronary arteries. So multifaceted test, easy to perform, a bit prolonged than CT scan, which takes very short time, but then it really gives good amount of information in terms of and actually complements things. So at times you have to make a choice as to which test to do first and why. That's three-dimensional echocardiogram, just a gentle mention that we have now machines which are pretty much capable of producing three-dimensional images whilst doing procedures or even assessing mitral valves and aortic valves to actually assess which leaflets, how much regurgitation, where to go for. And the whole idea behind these technologies is to get the best results from any interventional or surgical planning you are doing. That is the underlying aim to get these technologies on board. Smart Echo, I'm sure you guys are aware of it. Point of care echocardiogram machines now on iPads and smartphones are easily available. Lumify is one of the best ones I've tried, actually. And there's few more which have come through, I think, and they give you really good images. You can't do a full scan, but you can actually rule out most of the stuff which you want to in a pretty much couple of minutes time at the point of entry. So that's very useful. I would like to mention arrest trial, cardiac arrest. This is the very latest in the out of hospital arrest, the first of its kind randomized, under inverted commas, study from London Ambulance Service. You know, they tried to take patients to DGHs on non-cardiac arrest centers versus cardiac arrest nominated centers in a randomized fashion, which at the point of entry they had to be told. So it was as best randomized as possible. And it was being discussed in the ESC meeting at the end of August by Simon Redwood. And there was no difference whatsoever in terms of deaths after resuscitation in the community with ROSC. And the same night, Lancet decided to publish this because they felt that this would have major implications on, you know, the thought process that every cardiac arrest has to go to cath lab, every cardiac arrest has to go to the best possible center. No, they have to go to the nearest hospital. But most of the determinants were actually pre-hospital. So for that reason, this trial was negative and there were no obvious surprises. So this is just to keep in mind. The other thing which has come a bit more proactively, and the first of its kind, in a way, that we are now phenotyping patients who survive cardiac arrest in terms of survival probability as to 4 phenotypes: non-shocked patients, patient in shock, patient who have purely hypoperfusion, and patients who have hemometabolic, mainly kidneys, especially liver and kidneys, hemometabolic shock. And you can see that it's this group which does the worst compared to the non-shocked one, of course. So that's one way to think about this. There are some scores available now: Sky 5 and Miracle 2 score. Miracle 2 score is all over the news. You could just Google that and you can see what it entails. Let me just see if there's something on the chat box. Why do drug-eluting stents need antiplatelet therapy? Well, because if they're coated with drugs, then there are polymers on them. The polymers are coated with the drug. They release the drug for up to 6 to 12 months or even longer, actually, conventionally. So the polymers are highly thrombogenic, and the polymers, that's the reason why polymers need enhanced anti-aggregation, antiplatelet therapy. But the current generation of drug-eluting stents do not require the longer or the longest periods of DAPT. Does that answer the question? I guess so. So it's due to the polymer which contains the drug and releases it slowly into the coronary circuit or around it, so that there is minimal neo-intimal proliferation. So back to this. Is everyone clear about this? So you've got 4 phenotypes post-arrest who have ROSC, and then that's a neuroprognostication. That's again something very new. It's been the first pilot of this has been conducted in the Essex Heart Center just very recently, and this is the way forward, that you're going to have to formally neuroprognosticate patients using a combination of tests. I know it's a busy slide, but just gives you an idea of survivors of cardiac arrest, and then how you go forwards, how you formally, objectively assess them, give them a prognostic score, and then have chat with family, so on and so forth, about how you go in terms of their ongoing care, so on and so forth. So, okay, so apologies, my phone is dying. I haven't had a charge at work. Well, ideally, you should sorted technology out beforehand, ideally. Anyway, paradigm heart failure study. I'm sure you guys have heard about Entresto. Can somebody tell me Entresto and how does it work and what dose? Can somebody tell me what's the starting dose of Entresto and what is Entresto? Shout out, please.
Isn't it valsartan with sacubitril? Is that it? But that's all I know
Yeah,
about.
excellent.
In a
Excellent.
heart failure to start it. Yeah.
Yeah, excellent. So that's the dual ROS inhibition, which you want to achieve in heart failure, which is more of a ROS overactive mediated, most of the systolic heart failure. You want to really suppress the ROS system as much as possible. Entresto has certain prognostic advantages over conventional ACE ARB, provided the patient can tolerate it, provided there's no hypotension symptomatic, provided there's no hyperkalemia. So those are the certain nuances with Entresto, but majority of patients who have stability can achieve good results if you're able to titrate them to the highest possible doses. It comes in 3 doses. The starting one is 24, 26 milligrams, and then you go up to the highest dose, and with potassium monitoring, blood pressure monitoring. So aim to switch majority of your patients, and they have all sorts of effects, vasodilatation, natriuresis, aldosterone suppression, and of course, anti-inflammatory, anti-fibrotic. So basically, that's how it works. And majority of our patients do get Entresto, especially the younger ones. It could be an issue where you think about prognosis in elderly patients as to whether they would benefit from it. Yes, no. That's a bespoke decision. So that's just to keep in mind. You will be prescribing this now and then. And that's to switch. How do you switch it? Basically, you have to stop the ACE inhibitor or ARB for about a day and a half approximately, and then start the dose, and then keep checking things. At some point, increase the dose and go up to the highest possible dose, which is the one you want to achieve, because unless you do that, you won't be able to get the same results as the Entresto clinical trial had. Okay, so at which point would we consider Entresto first line or refractory? Well, first line, to be honest. Okay, is that clear? It's not meant for refractory heart failure. It's meant as a default strategy. Wherever you want to think of ACE or ARB, think Entresto. Provided there are no contraindications, provided there are no concerns around potassium or low blood pressure. All right. So I don't need to emphasize much on eplerenone, spironolactone, because of the FSS and the RAIL studies showing that these relatively cheap drugs had prognostic benefits, and even post-myocardial infarction, they could provide benefits up to 30 days of mortality reduction with cardiac arrhythmias. So they are used pretty much default. I don't really understand why people sometimes prescribe 12.5 milligrams of eplerenone once a day, whereas it's so hard to cut that tablet into half. It should be default 25 milligrams, provided there's no hyperkalemia, right? That takes us to something which you guys would be very well aware of, is the SGLT2 inhibitors, as to why and how they've suddenly landed on scene and they've completely taken over the care. The GLP one are agonists like semaglutide and other similar medications as to reducing cardiovascular risk, providing pleiotropic effects like statins and they're very much on the board currently for the right reasons summarized in front of you here. Pretty self-explanatory, and in particular, some of the recent ones have established reduction of events even in people with established cardiovascular disease, and that is a very, 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 very important point to take home. And that's perhaps just some of the common examples. The SGLT2 inhibitor is a very interesting medication from my point of view. I've studied it for maybe a good number of years, used it quite a lot. I haven't had any major issues. Initially, I had concerns, but to be honest, it's something which you guys wouldn't have discharged heart failure patients without, unless they were contraindications, elderly, or something like that. But it just works very interestingly by causing glucosuria, and then having a multitude of effects like a statin, in a way where it effectively reduces the sympathetic nervous activity, and also protects the kidneys at the expense of a reduction in EGFR, and then you carry on. And now we have evidence, most recently, that you should use it in even heart failure with preserved ejection fraction. Breathless people, no other cause. Breathless people, mild LV impairment. Breathless people, significant LV impairment. All across the board, this has evidence that this would either improve symptoms or improve symptoms and prognosis. The poorer the LV function, better the prognosis, provided the patient can take it. There's no risk of DKA, doesn't have type 1 DM, etc., etc. That's just a general summary slide. So that's a stepwise approach that you do assess actually a little bit in terms of as to whether the patient is suitable or not, and then you prescribe, monitor, be careful about the renal function, and explain as to what they might expect, so on and so forth. DOACs. How many of you have had to reverse a DOAC? Come on, anybody? Yes, no? Well, okay, so let's see. 3, 4 responses. No. Yes. Okay, well, do you want to... Okay. Oh, is that yes? Yes, yes. Anybody who's had to reverse? Right. Jana Holmes, Charlie Dolan. Do you want to shout out and tell us? Daniel Brown, tell us when you had to reverse a DOAC and how did you do it?
They were having a large bleed, so I just called the hematology reg and they told me what to do. I can't remember what we...
Yeah, but you had the experience of reversing a DOAC.
We had a pre-theatre chap who'd taken a Pixaban within the 48 hours before he was going to theatre.
Okay, right. Yeah, that's right. Expensive decision. Correct. So, yeah, I just wanted to bring this in and throw it in the mix. We have this andexanet for apixaban, rivaroxaban now. We have Praxbind for dabigatran. So we've really come a long way in this, and there is a universal antidote being worked around, still not available yet. And this is the general sort of thing which is you only use it unless there's no other option and there is hemodynamic instability, hematologist involved, and then you consider the actual medication rather than going just upfront with it. And you do some lab tests and you do want to know when was the last dose, so on and so forth, and whether it was a major bleed, mind bleed, life-threatening bleed. I personally have come across 1 or 2 patients, but not more than that. So overall, full circle, I think more than 10 years since dabigatran came along, that speaks of the safety profile of those medications. And that's the universal DOAC antidote, ariprazine, which is in development currently for a couple of years, and we should know more a bit later on. That is just an injectable anti-lipid therapy. Just say yes, anybody who has heard about this in statin refractory and other options refractory patients with hypercholesterolemia. And I'm sure some of you would come across in your community posts as some patients on these certain medications through endocrine clinic or through, basically from endocrine clinic and getting injections for LDL reduction in high-risk patients. Cardiomyopathies, there's a lot of emphasis currently on hypertrophic cardiomyopathy, DCM. So there's all this, just a fantastic graphic from ESC this year, which labels the full range of hypertrophy, dilatation, non-dilatation, arrhythmogenic right ventricular cardiomyopathy, and restrictive cardiomyopathy. So it just shows how progressive we are in terms of phenotyping the cardiomyopathies and working them up properly, stepwise, and then providing bespoke care. But phenotype is the main thing that you really need to know what you're dealing with. Its risks, genetic testing, multidisciplinary care, involving every single agency, colleague, team, and then going forward. Those with end-stage heart failure within this country, we don't have much transplants because of organ availability. And left ventricular assisted device, LVAD, as we see, the regional centers have changed the course of, we have quite a few patients in our area under our care with LVADs living as normal life as possible. It's taken off the age as a cutoff point, to be honest, and it provides, provided there's no complications, quite a good amount of number of years to people and acts as a bridge for transplant. And that's LVAD. That's how the LVAD looks like. There are specialist LVAD nurses who regularly check on the patients. Patients go for regular reviews, so on and so forth. And it just has transformed the care of heart failure or refractory end-stage heart failure patients around the world. I just want to finish with two things quickly. You would know, you know about TAVI. You must have written the word TAVI many times. The key thing to know about TAVI is that it's not a risk-free procedure. It's for symptomatic severe aortic stenosis for people who are not fit or deemed fit for surgical aortic valve replacement. However, that's been questioned now that, is TAVI same as AVR result-wise, which could be the case going forwards. It needs proper assessment, good MDT, proper preparation, and then it can be a very rewarding procedure for majority of the patients. And you've got loads of options as to, what you could use. In our region, we use a couple of things. And Leeds, as a region, we have one of the largest services, perhaps, if not in the world, in the country, of course, as a regional TAVI center. On the same line, you can clip the edges of the mitral valve when the left ventricle is enlarged and you have mitral leakage coming through, again through catheter means called mitra clip. Again, that is regional service, and that's a mitra clip system which goes in and clips the valve, tries to narrow it down to minimize the regurgitation. It is available. It is being done routinely. There has to be a very careful degree of case selection, how you do it, in whom you do it, how you offer it, what complications, so on and so forth. Just to keep in mind that there is a percutaneous treatment available for functional mitral regurgitation. For structural mitral regurgitation, you need to offer, treatments which would either replace or repair the valve differently. So that's the sort of mitra clip system. Okay. This has been there for a long time. Percutaneous closure of either atrial or ventricular septal defects. Nothing new, actually. And I don't really want to spend any more time on this. just the last word before we finish. Arrhythmia detection is one of our current highlights. We've now gone on to this little thing called Reveal Link or insertable loop recorder, where we can just insert it rather than implant it. These were the implantable ones where we had to make a good cut and then put it in and then sew up. But this can be just inserted. If you're not getting anywhere with monitoring conventionally with a 24-hour, 72-hour, 7-day event recorders and not getting anywhere, you can leave this for 2 to 3 years and patients can be monitored and for symptom rhythm correlation. Alternatively, you also have up to 30 days maximum of these patch or different kind of wearable technologies, which can give you good amount of data. And the sweet spot is about 10 to 12 days. But you really have to take a good history and suspect something sinister before you commit to these sort of monitoring systems. Mobile ECG Holter, there's loads of options in the market. You only have to choose what maybe FDA approved, CE marked, and all that stuff. Patients can remotely send the data from home, which can be received in our departments, analyzed and correlated if they have had any symptoms. And this is just pretty much almost we are recommending to anyone who has palpitations through cardiology consultations and in our clinics, anybody who can afford and spend up to 80 to 90 pounds and has recurrent palpitations or any concern regarding heartbeat should have a AliveCore device, which is the most clinically validated personal ECG system in the world. The price hasn't changed, however, in the last maybe 5, 6, 7, 8 years. Well, thank you very much. Any questions? I'll be more than happy to take them on.